So I want to talk to you about the SOV, which stands for the superior ophthalmic vein. And so the SOV, the superior ophthalmic vein, is the major draining vein of the orbit. And so when we're looking at the orbit from above, the vein drains the orbit and it goes into the cavernous sinus. Now there's also a inferior ophthalmic vein as well, but it's not as predominant as the superior ophthalmic vein. And so when we see a superior ophthalmic vein that's occluded, the blood flow will go the wrong direction because it can't get backwards. So one of the ways that this can get occluded is if you have a cavernous sinus fistula. So that's an arterial to venous fistula, where arterialized blood from the internal carotid artery or the external carotid artery branches are forcing the blood to go retrograde into the orbit and enlarging and possibly thrombosing the SOV. So the first thing you got to be thinking about when you have an enlarged SOV is a fistula, carotid cavernous fistula. Usually these are slow flow fistulas. The high flow fistulas, Barrow A classification. The A fistula is direct fistula and it's high flow. And so those are easy to diagnose because the eye is really bulgy and red and they have a bruit and there's trauma history. The low flow fistulas are B, C, and D, which are branches of the internal carotid artery, the external carotid artery, or both. And these are slow flow fistulas. So there's slow and low flow fistulas, B, C, D, in the Barrow classification because they're just branches, meningeal branches of the ICA and ACA. The other thing that can cause the SOV to get enlarged or thrombosed is if you have the same problem of fistula, but it's in the orbit instead of the cavernous sinus. Or if you just have something pressing on the SOV, like a mass or thyroid eye disease. So thyroid eye disease can also cause SOV enlargement just from mass effect pressing on the vein drainage system. You also have to worry about infectious thrombosis, and that's cavernous sinus thrombosis, which can be septic or aseptic. Septic if it's infectious. The same process can occur in the SOV. And the clinical signs we see when we have an SOV that's enlarged, dilated, or thrombosed is because the blood can't leave. You're going to have blood accumulate in the muscles, which is going to cause diplopia. You're going to have blood in the muscles and the fat, and that's going to cause proptosis. The eye is going to be red because the blood can't leave, and so there'll be conjunctival injection, arterialization if it's high flow. And you're going to have increased intraocular pressure. And the reason you're going to have increased intraocular pressure, as you know from the Goldman equation, the intraocular pressure equals the inflow, F, over the outflow, C, plus the episcleral venous pressure. And so when the SOV's pressure is high, the episcleral venous pressure will be high, and the intraocular pressure will be high, causing a secondary open-angle glaucoma. Inside the eye, we might see vein occlusion or just dilated veins or venous stasis. So we have to look for all these things. And it can produce an optic neuropathy, either anterior with a swollen disc or posterior with a retrobulbar optic neuropathy. The way to make the diagnosis is standard catheter angiogram so that we can see where the fistula is, see if it's thrombosed. You need to image the orbit first and exclude mass lesion. So you need to know a little bit about the anatomy of the superior ophthalmic vein.